Hi, everybody. Welcome. Can everyone online hear? Let's keep going. Okay, great. Welcome to Breakfast with WACh, our first Breakfast with WACh of the year. For those of you who are new to WACh is the Global Center for Integrated Health of Women, Adolescents, and Children, where we focus on health throughout the life cycle. And I'm really pleased to introduce our guest speaker today, Dr. Ajay Khera. Dr. Khera is someone who I've had the pleasure of starting to work with over the past few months as an external advisory board member of the Insight to Impact project. But I've been hearing about Dr. Khera for years and years and years as a change maker in India, someone who can really help move policy into practice. So for those of you who are interested in implementing, Dr. Khera has had an eye over both evidence-based interventions, implementation, and policy in India, regionally and globally for a long, long time. And Dr. Khera is currently a senior public health expert who's a country representative at EngenderHealth in India. Previously, he was the commissioner for the Mother and Child Health program, including adolescent health, nutrition, and immunization at the Ministry of Health and Family Welfare in the Government of India. He's a medical graduate with a postgraduate qualification in public health, more than 25 years of experience in public health programs at the national level. He's worked with the National AIDS Control Organization in the Government of India and the National Integrated Disease Surveillance Program, Ministry of Health in Oman, the WHO Myanmar, and the National Institute of Communicable Disease. He has led the investigation for several outbreaks of communicable diseases, represents as a member of various high-level technical expert groups, and has published many articles in national and international journals. I feel quite lucky that he supports us in the Insight to Impact project, and he happened to be in town for the birth of his grandchild, so we snagged him over here. And feel quite lucky to do so because he's headed back home in just a few days. So thank you so much for joining us. Thank you all for coming in person and online, and over to you.
Thank you very much for an excellent introduction. Very good morning and Happy New Year to all of you for 26. And greetings to all of you on behalf of EngenderHealth. Presently, I am working as the country representative for EngenderHealth. And I'm so pleased to be part of this, so-called breakfast lecture series. And thank you very much for inviting me to talk on a topic, which is not being talked about so commonly. And then the topic which has been given to me to speak is on the subject of, reproductive health in India. And people, call family planning in short, but I think reproductive health is beyond family planning. Because generally, when you talk about family planning, it only conveys that you're talking about population control. I mean, it's kind of a synonymous with that, presuming. But I think reproductive health is beyond family planning. So I will, try to tell something, that where do we stand? What is the situation of reproductive health in India? And what are the various insights, from a evidence, from the data point of view? And then if you really want to make a change, want to improve the reproductive health scenario in India, what really needs to be done? So that's my, kind of a focus of my presentation. And as you know that, we as a global health community, we are all really keen to achieve our sustainable development goals. And I really want to convey that reproductive health is one intervention, which fulfills the needs of many of those sustainable development goals, whether it is of education, whether it is of gender inequality, whether it is about maternal and child health, or whether it is, women's participation. And I think if we really want to have a real socio-economic development of the community, I think reproductive health investment is one investment which can really make a difference. I would like to, start with a kind of an example, particularly in the Indian context. If we find a girl who is, 16 or 17-year-old, and she gets married. She's taken away from the school, and once she is not educated, she doesn't get the employment. And then she's 17-year-old girl getting pregnant is like baby giving birth to a baby. You can understand. So I think it has an implication on the health of the mother. It will lead to malnutrition. It will lead to loss of education. It will also lead to loss of job opportunities. So she becomes kind of a dependent on the husband. So we really want kind of a gender equality, and I think reproductive health investment is one investment which can really help in improving the education, the financial status, and the health of the both mother and the children. And you must have seen the global community is talking about, because we're all committed to improving the health of the mother and the children. Now, for improving the mother and the children, people have at the global community has come up with an idea, as I said, WACh, or people call it RMNCH, reproductive, maternal, newborn, child, adolescent health. Because if you really want to improve the health of the newborn, it has to be a complete life cycle approach. You can't have a vertical approach to newborn health. If mother is not healthy, you can't have a healthy newborn. And if the adolescents, girls are not healthy, you can't have a healthy mother. So I think the investment has to be across the life cycle. And within that life cycle approach, there's a component of R, which is called as the reproductive health. But people generally equate it with the family planning. So that was a kind of overview of the whole thing. What I'm going to speak about. So this is the agenda of today's the presentation. I'll talk about gender health, about reproductive health, and I'll talk about some insight which I'll share with you with some data sets, and then what are those opportunities for strengthening the reproductive health in India. Now about the EngenderHealth, we have a headquarter in Washington, and it's a global organization with more than 50 years of experience, and we are present in around 10 countries in Asia and Africa. And in India, we are working for the last more than 3 decades. We work closely with the governments, the state governments, with the community, and we are committed to advancing reproductive health and rights and gender equality, because gender equality and the reproductive health and rights, they are both kind of so interlinked together. And our modus operandi is we work with the local organizations, we work with the civil society organizations to promote country ownership and the leadership. So that is the kind of the approach we follow as EngenderHealth. Now, as I told you that there's a component of R within that RMNCH, which is an integral part of the RMNCHA, and we call it as a critical life-saving intervention. I think I already explained you that it impacts health, it impacts economy, it impacts development of the population. And there are some data set which I am quoting, that 40% reduction in maternal mortality in last 2 decades is attributed to the reproductive choices, including fertility reduction, to increase contraceptive use. So that is the power of the reproductive health intervention, and it has really impacted the maternal mortality. I think you can understand if there is unwanted pregnancy, unplanned pregnancy leading to unsafe abortions, there's so many things, or adolescent pregnancies is also high risk pregnancy. So it has been said that 40% of the maternal mortality has happened because of the investment in this reproductive health. And then another statement is, the fact is that every dollar spent on the reproductive services or contraception reduces the cost of the pregnancy related and newborn care by $3. So from an economic point of view, because generally, the policy makers look at the investment, from a point of view of economics. And then also, it also increases the women workforce participation, leading to improved economy and the gender equality. I think this is, one area which really needs to be highlighted while making an investment in the reproductive health. That's why, we say that reproductive health, refers to the rights, the choice, and the dignity, and it is not merely a population control or a fertility. So that's a kind of a overarching, the concept. Now, this is, the snapshot of the reproductive health in India. Now, India has a population of, 1.46 billion. I mean, the 1/6 of the world population, India's population, it's like a continent. And there are around 450 million women of the reproductive age group. You can understand the needs. And then around 24 million births happen every year, which is equivalent to the population of Australia. And we are now, there has been a lot of, significant improvement has happened in the overall space of reproductive health broadly, that our national total fertility rate has come down to 2.0. And I think you all must be aware that we say the population gets stabilized when the TFR becomes 2.1. Now the national average is now is around 2.0, less than 2.1. So that means there are indications that the population is going to be stabilized, but it will not happen overnight because countries like a continent and there are different states and there are various states, where the TFR is even more than 3. So this is the national average, but there are states, where the TFR has even gone less than 1. I will, give you some examples. So it's like a continent, which you find, and we are expecting to be stabilized by 2056. And then there are 24 million individuals do not have access to contraception. And there are around 2 million annual teenage pregnancies happen. And the interesting part is that, 47 births are unplanned. 47% means every alternate pregnancy is unplanned pregnancy. And this is not in India. I think if you look at the global data also, if you look at the global average is also the same. People have, the populations are declining because of other reasons. But if you look at it in terms of, reproductive choice or reproductive rights, you will find that around every alternate pregnancy, even globally also, are unplanned. And I told you about the maternal mortality ratio, which is closely related to the reproductive health, has also gone down to 88. Although the so-called the SDG target of 2030 is 70, and hopefully we may be able to reach that. And infant mortality rate has also gone down to 25. I think there has been a significant improvement in the overall maternal and newborn health. And one of the, the reason could be the investment in the reproductive health has really helped. There are other interventions also, but this is also one of the interventions which has really helped. Now, I will give I have 10 insights, from a data point of view, from an evidence point of view, how this whole reproductive health scenario is happening in India. If you look at this graph, this is the graph where we have tried to collect data from something called as the National Family Health Survey. This is nothing like reporting. This is absolutely a third-party, independent family health survey which is conducted. And it happens, after 5 years. Now it is happening after 3 years, from 1992 to 2020. You can say that. The total fertility rate used to be 3.5. The average woman used to be 3.4 children, but now the average has gone down to 2.0. So that is the TFR, declining TFR. And then simultaneously, if you look at the so-called the reproductive health or contraception or family planning in short, it has moved, the modern contraceptive prevalence rate has moved from 36.5% to 56.5%. A significant improvement has happened, in this area. But there are, kind of 7 states where TFR is more than 2.1. States like Bihar, Uttar Pradesh, Jharkhand, we find that more than 2.1. But there are 31 states which are below replacement level. And there are 11 states where there is a cry actually, where the TFR has gone to 1.6 or below. States like Goa, Jammu Kashmir, Delhi, Punjab, Chandigarh, and so on and so forth, West Bengal. And there is Sikkim is a state which has a TFR of 1.2. So there is a kind of a cry happening in many of those states that their populations are declining. And even the policymakers, the politicians, they are thinking of, closing the family planning program. It's kind of a knee-jerk reaction, which is not a right approach, because, family planning or reproductive health is a kind of investment which has to continue, as per immunization program, new cohort of children will keep coming. Similarly, the new cohort of couples of the reproductive age will keep entering into the reproductive age. So they need to be informed, services need to be provided. It has to be a continuous investment. It is not that TFR has gone down, that means that you just stop the investment. So there is some kind of a knee-jerk reaction, but we are kind of doing an advocacy, talking to the policymakers. It is not the question of the TFR, it is the question of every pregnancy has to be a planned pregnancy. And we should avoid things like adolescent pregnancy, which is a high-risk pregnancy. So there are kind of variations, but that's why I'm saying TFR at the state level gives us a different picture. So that means our approach, our intervention has to be area specific or state specific, you can call it. The second, the insights, if you look at it, further, more closely about this modern contraceptive prevalence rate, we said 56.5%. And you also must have heard about, something called as the unmet need for unmet need. And unmet need, when you do the National Family Health Survey, we go to the women's and then talk to them, understand, and then we find out what is their unmet need. And if you look at the different age groups, 15 to 19 year age group versus 45 to 49 age group, you find that overall it used to be the unmet need was 17.5, 17.8 in the young population, in the youth population. But as you go to the later age groups, the unmet need has decreased. So that means, we need to really address that unmet need of the youth population, which is a big chunk, And we say that the unmet need for contraception among youth is around 2 times more than the overall unmet need. And overall unmet need in the country is around, 9%. So 9% between the 15 to 45 year age group. But if you look at the smaller cohort of 15 to 24, you find, around 17%. So there is a real unmet need, And then on the right side, we spoke about, various methods of contraceptions and how many are using, how many are not using any method. And if you look at the modern methods, only 20% are using, 20 to 24, 34% are using, and then 15 to 49, around 56% are using. And then the large chunk of 2 million adolescents have the unmet need. This is, as per the Good Measure, Institute estimates. So that is the second insight, kind of a differential, which we have to know. And then the third important, the insights about this, we call it, choice. One is, access. So I find lack of access, there's unmet need among that youth population. But then the next question comes is the choice. And you look at the contraceptive mix, and the contraceptive mix, among youth is highly skewed towards short-acting reversible contraceptives. And even if you look at those, in this particular graph, in the 15 to 19 year age group, 20 to 24 age group, and then the 15 to 49 age group. And if you look at the last 15 to 49, this combined age group, you find, 67% of female sterilizations, which is a real cause of concern, because people are only adopting a method of, permanent method, which is a sterilization, which is not a good kind of a method mix. So we call it, skewed kind of, method mix. And for the young people, we find only the pills and the condoms, the reversible contraceptive, short actings methods, even if whatever contraception they are using short acting methods. And as you know that the short acting methods, there are possibility of the failures, there are possibilities of relapsing. But somehow, this is the kind of the pattern. So we really have to, improve that, method mixing. And then the fourth insight, which is also very critical, from a reproductive health point of view, because early marriages, can you imagine that, around every 23rd means, every fourth girl is getting married before 18 years of age. With a huge population of 1.4 billion, every fourth girl in India is getting married. But I'll tell you that this used to be 54% 5 years back or 10 years back. NFHS data. Every alternate girl used to get married. But in terms of, if you look at it, change, yes, things have drastically changed. From 50%, we have gone down to 23%. But even if the 23% is quite high, and you can understand the implication of, early marriages leads to pregnancy and the loss of education, lot of employment opportunities, and then the gender inequality also goes on. So I think it's a kind of a vicious circle, I think we need to break that vicious circle. So 23% marriage, teenage pregnancy, early marriages. And then there's a resultant kind of, teenage pregnancies also happen. Overall, we see around 7%, the pregnancies, adolescent pregnancies happen in India, which roughly turns down to 2 million adolescent pregnancies every year. So 7%. And then, there are kind of a lot of variations from state to state. State like Tripura or Telangana, we find 42% early marriages. Like Bihar, 41%. I mean, it used to be 80%, 70-80%. That means every girl used to get married before 18 years of age. But things have changed. But I will still say that we need to continue with this kind of investment, continue to talk about reproductive health with the adolescent, with the youth population, with the policymakers, that these knee-jerk reactions are not fine. And we are all aware that adolescent pregnancy is a high risk, and because it is linked to unsafe abortions, maternal infant and mortality, and it also leads to intergeneration cycle of poverty. Because she is unemployed, obviously the income gets affected, and leads to malnutrition. We are really struggling to address malnutrition. Unless we address this issue of early pregnancy or early marriages, we may not be able to address the issue of intergenerational malnutrition and poor access to quality education. And there are also, a number of issues like provider biases, limited privacy, confidentiality. Young people, they do not prefer to go to the public health system, because of the judgmental attitude of the healthcare provider. Confidentiality, privacy is not provided. So I think we need to change those kind of, mindset of even the health system as well. So this is the slide which, talks about the pregnancy as well as the early marriages. And then if slide 5 is again, the figure which I showed you is the national figure, and then further, geographical variations also noted in the so-called the adolescent pregnancies. And here, I have, tried to make, kind of a comparison between the NFHS 4 and the NFHS 5. That means 2015 and the 2020. In 5 years' time, the adolescent pregnancy has also gone down from, 9% to 7%. I think 2% significant drop, but I think this drop need to continue more. But there are states, there are areas like Tripura, where adolescent pregnancy rates are to the tune of 19%. West Bengal, 18%. I think, we need to look into it. Why so much of adolescent pregnancies? Why so many early marriages happen? There could be a variety of, social reasons behind it. Because of the security issue or education issue, poverty, schools are not there, schools are far away. We really have to go into the depth of it if we really want to address this issue of. So that means reproductive health requires not only the intervention from the health department, it requires, multi-sectoral kind of approach. Because reproductive health investment impacts the outcome of, other parameters, other, so-called the sustainable development goals. And then, we also looked at that there are 118 districts to develop a focused attention to address this issue. So there are 118 districts where we are finding, more than 10% teenage pregnancy happening. That was the insight 5. And then, there are some kind of, qualitative insights. We try to understand why this is happening, there is an interaction of the health workers among the female non-user is quite low. We find only 23.9% of the health workers speak to the non-users. So that means, the health workers are hesitant to talk to the group of maybe young people or the potential users. They are not reaching to them. Maybe there are societal kind of reasons behind it. But the fact is that the information is not reaching to non-users. So it is not that they have the information and they are not using it. So I think there is a potential if we provide them the information, if we try to reach out to non-user, there is a possibility that we may improve the unmet needs among those populations. So that means improving outreach is one way with a special focus on particularly those areas where and the percentages are there like 35.8% workers do not talk to the non-users Karnataka. So they need to be, these areas needs to be addressed. And then there are issues like insights like lack of quality counseling on reproductive health. I mean, this is one area, because just by provision of a services is not enough. You have to get a confidence of the woman, and that's why we as the reproductive health experts, we monitor the quality of the reproductive health services by quality of the counseling, because counseling plays a major role. And because only 47% of the women using modern contraceptive were informed about possible side effects. You must have seen the intrauterine devices or the cooperative, we call it, In the initial few months, there might be excessive bleeding during the periods when we're aging. Or if the woman is on oral pills, in the initial period, there might be less bleeding, which is called as the amenorrhea, which are quite normal. But unless those side effects are explained to the woman, otherwise what happens, they just drop off. They will get their IUD removed, they will stop taking oral pills, because they have not been briefed, they have not been properly informed about those, the side effects or the expected side effects, and which are temporary in nature. And similarly, even people are not told about the method mix. 54% were informed about other contraceptive method available. I think we have to give them a basket of choice, and then depending on the case-to-case basis, it has to be. But we could find around 67% went for a sterilization operation, permanent method. They could have been opted for long-acting reversible contraceptive. The number of options are available, or implant for that matter. And only 1/3 of the adolescents use contraceptive during the most recent sexual engagement. So that means, there is a lack of information, lack of awareness. And I think comprehensive sexuality education is one area which nobody talks. And it is a very sensitive area, politically or otherwise also. So this is, one area which is lacking, but there are efforts are there in that direction to provide them right set of, comprehensive sexuality education to the adolescent in the schools or in the colleges for that matter. And then the insight number, the 8th one is the, lack of, male engagement on reproductive health. This is, one area which is a big area, male contribution is 17%, including condom and vasectomy. And 37% of the men report that contraception is a woman's business. I think we really need to change this kind of, dimension of reproductive health, that both have to be responsible, both have to actively participate, understand. But the scenario is only 37 say that, no, this is not my, that's the kind of the feeling. So this has to be conveyed very clearly. And as EngenderHealth, we have come up with a number of, packages. We call it, MAP curriculum, engaging men as partners. Curriculum is there to engage, men by the community health workers. And then I repeated the same thing, that 1/3 of the adolescent use contraception in the most recent sexual engagement. And then the insight number 9 is, in terms of, gender inequalities, which is quite rampant across the world, within India. But, one of the things which we continue to note as the gender-based violence, because gender inequality happens in different forms. And gender-based violence is a kind of, we call it, extreme form of gender inequality. And we noted down that as per the National Family Health Survey conducted in 2020, that every third woman between the 18 to 49 year experienced gender-based violence. Every third, which is so high, which basically, impact their decision-making authorities. And then there are kind of, state-wise variations. And the globally also, situation is not very good. Because gender-based violence is not only physical violence, it is emotional violence, financial, or maybe, using what method of contraception, early marriages, adolescent pregnancies. These are all parts of the gender-based violence. So restrictive, gender norms and the gender inequalities are replicated in the health system. So I think it's high time that within the health system, there's a need to do a gender integration in the health system. People need to be sensitized about those issues, because we are finding provider biases, because whatever happens in the community gets replicated in the health system as well, because after all, people who work in the health system, they also belong to the same community. So I think there is a real need to do a gender sensitization, gender integration within the health system. We recently attempted in India a gender integration within the nutrition system, and we came up with, kind of a small capsules, small videos to sensitize, healthcare providers. And to my mind, at least India, the health system is now quite mature to take up, do new additional things. And gender inequality can address many of those issues, whether it is around malnutrition or whether it is around, maternal and reproductive health for that matter. So because the decision making on sexual and reproductive health and rights depends on how the woman empowerment. So I think the gender inequality really helps in addressing those things. And then the last insight, this is also quite unique, and it's high time because the government, the policy makers were investing in family planning and reproductive health, considering populations as a burden, to do a population control. And they took it as their own initiative. And the whole family planning or reproductive health program were the government funded program, public health programs. But now if you look at this, there is the private sector, there's a limited engagement. Generally, if you go and speak to the private doctors, they say, the contraception, those reproductive health information choices, it is, the domain of the public health system. But it's high time because 70% of the healthcare services in India are being provided by the private doctors. 70%. So I think, unless we engage private sector doctor, we will not be able to achieve our real goal of, universal access to the reproductive health or universal health coverage. And the status as of today is less than 10% of the women rely on private sector for reproductive health services. Less than 10%. But for medical care, 70%. So I think there is a kind of a big kind of differential. So I think these are the areas which really needs, kind of a further going deepening efforts and intensifying efforts. So these were, the kind of 10 insights, which we try to understand that in terms of reproductive health, where are the gaps, where are the challenges, and these are all kind of evidence-based information which I'm sharing, and this is available from the family health surveys or other surveys which have been conducted. And then looking at this, the government of India has also come up with something called as the FP 2030 vision, and the vision is to provide access to the high quality, comprehensive family planning / reproductive health to all people of reproductive age group. by ensuring equitable, affordable, and appropriate choices and information till last mile through the improved health system and the community engagement within the country's universal health coverage framework. So this is the kind of the commitment which has been made by India. And then these are kind of a specific commitments, specific areas where we propose to the government of India is proposing to work on. One is, expanding the range and reach of contraception, promoting healthy timing and spacing of the pregnancies, and then, scaling up, program like MPV, which is called as the Mission Parivar Vikas Program. It is a targeted, district-based intervention program to address the high unmet need in those districts. District with a high unmet need, there is a special targeted intervention, targeted investment, and then obviously intensifying social and behavior change, and especially engaging young people with the information and the services, and then strengthening the civil society's commitment to create awareness of the reproductive health communities and the services. So these are 4 or 5 commitments which are there. Now looking at those commitments, I'll stop here. If you want me to stop, I can stop. If anybody has question, then I'll go to the next part of my presentation, maybe another 10 minutes, where I'll talk about that based on those issues and the challenges identified, evidence-based challenges. What are those opportunities? What needs to be done? And what are those opportunities for strengthening India's reproductive health and FE programming? One is, the optimizing the basket of contraceptive choice. And I think I have already shared with you the evidence in terms of, skewed kind of, the method mix. So I think this is one area where we need to work on in shifting the contraceptive method mix to optimize the access and the utilization. And with a focus on, young people in particular, because young people have unmet need is very high. That was one. And second is, the adolescent and the youth reproductive health empowerment. I think this is one area. Just by providing services, it won't happen. I think we will have to find out some, innovative ways of engaging youth. And we call it, meaningful engagement of youth. At EngenderHealth, we have a lot of experience in this area of, engaging youth as, kind of a change maker in the community. And this is, one area where we can engage adolescent girls, not only as the beneficiary of the services, but also as the, providing information on the services. So they become a change agent in the community. So that's why we call it meaningful engagement of the youth. And then the third, the area which we think is in terms of strengthening the reproductive health program is something around, integrating preconception care. I think preconception area is one area which we think has a lot of potential, and particularly for the newly married women. If you speak to the newly married couples or women, I mean, they are not interested in a child immediately, but they do not have any information. Health worker do not go and reach to them. So that's why, the preconception intervention has a lot of potential in terms of, addressing the unmet need, and unmet need both sides, whether it is fertility requirement, if it is the case of infertility, or if they want to delay their pregnancy. So I think preconception period is the right period, and which can also help in addressing the undernutrition in the children as well. So that's, one area where, there is an opportunity for strengthening. And then, the fourth is, the post-pregnancy family planning or post-pregnancy contraception. And this is an area because as on today, in India, around 85% deliveries are happening in the institutions. Maybe around 10 years back, 50% deliveries, the births used to happen at the institutions. But now they are happening either at the public health institutions or at the private hospitals, but they are happening at the institutions. That means there are skilled people, the system is there. So I think there is a potential to integrate, reproductive health program with the maternal health program to increase the uptake of the postpartum contraception. Because at that point of time, the woman is fully motivated, fully, kind of understand the implications of the next pregnancy. So that is the right opportunity, if we really want to, improve that reproductive health scenario. And then promoting, gender mainstreaming and strengthening GBV identification and the reference. So there is a potential for, integrating, gender in the health system through various, approaches. We call it, gender, youth, and social inclusion approaches, and periodic application of gender markers. So we have a dedicated, package and module for doing the gender integration within the health system. And then there is also a curriculum to develop a gender competency among the healthcare providers. And then the increasing male engagement. I told you about that. There is a comprehensive men as partner curriculum which can be utilized. And there's a clinical training of the private hospitals, particularly on the NSV, non-scalpel vasectomy. And I think male engagement is one area where we need to really work on. It has to be an ongoing basis. And then private sector was another challenge which I noted. So I think we need to engage private doctors, chemists, through various mechanisms, through advocacy effort with the Pharmacy Council or Indian medical associations, and so on and so forth. And then in this new scenario, I think there's also need to integrate with other areas like, infertility. Because after all, reproductive health is not only a population control, it is also a fertility, kind of a management. If people are suffering from infertility, it needs to be managed. And the infertility rates are to the tune of 2%. And 2% is not a small number. If you convert this 2% into, it will come out to be million of women needing, infertility care. So I think there is scope to address this in the existing reproductive health program, particularly for the low fertility population group. And also, there is the potential to integrate with areas of, cervical cancer screening or HIV prevention programs. One can always integrate reproductive health services, reproductive health information in those programs. So these are, kind of the potentials we have for, strengthening. And this is my kind of, you can call it a summary slide or a last slide, which basically talks about, what is the next step, reimagining the reproductive health. So in summary, reproductive health is essential for sustainable development. It is linked to the gender equality, women's well-being, impact on MNCH education, future economic development. And there is a need to reposition reproductive health services not as a fertility control, but for promoting bodily autonomy, choice, and dignity, and as an integral part of improving health and nutrition outcome of mother and children. And targeted investment required in the adolescent reproductive health area. And we have to change gender and social norms, where actions are required even beyond health sector as well, particularly the girls' education. And then also, use those innovative information campaigns, technology, digital solutions, to communicate the right information and dispel myths around reproductive health, because there is nowadays so much of information is available. And then obviously we need to suitably engage, the private sector. So these are, kind of the thought process in terms of the overall reproductive health scenario in India. Where do we stand? What are those, evidence-based, the insights and opportunities and the next steps? And thank you very much for patiently listening to me here. Thank you. How much time I took, I don't know.
Perfect.
30, 40
Perfect.
minutes?
Yeah. I just want to say thank you so much, Dr. Khera, for you so elegantly summarized the Global WACh mission in your talk as well, really thinking about a life cycle approach, the interplay between adolescent, maternal, and newborn health, but also integration of reproductive health with other things like HIV, cervical cancer, nutrition. I think that really resonates with a lot of the work that we're doing, and it was so interesting to do a deep dive into India specifically. Thank you. We do have time for questions. We can go back and forth between online and in person. And Stephanie, do you mind being the conduit of the online? Okay, perfect. So let's start within the room. Open up the floor to questions.
You had mentioned the lack of access to contraceptives for the teenage population. I'm just curious, like, what unique challenges are that they have accessing the contraceptive. You mentioned education. Assuming there's other things like, stigma or not able to get it because of their age or other things like that. So I'm curious what some specialized issues are that population experiences and how you feel being addressed.
Yeah, no, certainly, because we are not only talking about adolescent, even the youth population, both put together as one piece. And you may be aware that there is a kind of a legal challenge. I did not mention, but now because you raised this point, that there is a law which is called as the the Prevention of POSCO Act, yeah. Prevention of Sexual Offense for Children against Children. Under that POSCO Act, any sexual activity before 18 years of age is kind of punishable by law. That means if somebody comes to a health worker that I want contraception, so that means he will have to report it. So there is a kind of confusion in this area. So we are working with the concerned ministry that POSCO Act is basically preventing the sexual abuse of children, but not the contraception. But somehow laws are used for other purpose also, and there is a kind of a misunderstanding by most of the mind of the people. So that is also hindering the provision of contraception to less than 18 years of age, particularly if they approach the public health system. That's one. And secondly, there is also a kind of a something around comprehensive sexuality education in schools is also one area that people talk about everything about health education in the schools, but people are not very comfortable in talking about about sexing. I think we need to break those kind of things. So that was the second. And then the third important thing is the provider bias, which is also quite rampant. People have a judgmental attitude and those kind of things. So that means if we really want to address the unmet need of the youth population, I think it has to be a very comprehensive approach. You have to address all those issues, and only then we should be able to address those unmet needs. Thank you very much for raising this point. It's really an area of concern, and we are finding out ways and means of reaching adolescent and youth. At least the married one one can reach, if not the unmarried. To start with.
Questions online? Feel free to raise your hand and we can call on you.
Okay, I have one question. You mentioned the Men as Partners curriculum as one solution to sort of bring more people into the conversation and increase education. How do you get men into the room to have that conversation and participate in that curriculum? And sort of a secondary question is, beyond men, how do you bring families into that?
Second question.
How do you bring families sort of into that conversation as well? Not just men, but like moms, mothers, fathers, grandparents who may be drivers of things like early marriages. How do you bring them into that conversation to increase their knowledge base?
No, certainly, I think it is not only the men, even the whole family, and particularly the mother-in-law, particularly in the rural areas of India. I mean, there's a lot of influence of mother-in-law. So there are kind of interventions which have been introduced to kind of talk to the mother-in-laws, engage them in the discussion, so that there is an improved acceptance by the young couples. But men engagement is, one area, at least, which is called as the couple counseling, being together, because after all, if they are having a child, belongs to both of them. So there are efforts in that direction. But as you rightly said, the mother-in-law is also one of the. And then, when you talk about it, it is not only the mother-in-law or the men, even the local leaders, sometimes they also become a resistance. So one has to create that kind of enabling environment in the community. That's why investment in reproductive health is important here. Because you find a lot of resistance from the community, from the local leaders. So that's why I said it has to be not only the health sector intervention, it has to be beyond health sector. It has to be multi-sectoral. Because reproductive health investments are going to help not only in improving the health outcome, but the overall, socio-economic development of the community. So I think we'll have to, we are doing that, but it's a kind of a lengthy process, time consuming. But thank you very much, I think, picking up that point on male as partners in parenting. Thank you.
I appreciated your comment about the quality of counseling and how challenging it is to ensure that people are getting the information they need, understanding side effects. I'm curious if you have either data or strategies to address discontinuation, after initiation, if people are experiencing side effects and then discontinue and or switch to a different method. Do you have data on discontinuation, or are there things that you're doing to kind of do that continuous counseling to support people beyond initial method selection?
No, there are challenges, particularly in terms of continuation of the various methods. And particularly, there is something called as the injectable contraceptive, which are given after 3 months. We had data sets, which indicate that, defaulter rate is very high. Around 60% of the women, default. And even so-called the intrauterine device, the quality of the counseling is not good. Then also, they get it removed. So I think, it has to be quality counseling right at the beginning. The choices have to be provided. So I think we need to improve the quality of the counseling. And it is not one time, maybe over a period of time. It has to be an investment.
You have had such interesting array of experiences, both as a high-level policymaker in the government of India and now as an organization that, as you said, is doing some advocacy around things like adolescent health and many other topics. And I'm wondering, in your experience, if you've observed either reproductive health or other topics, like best practices for how you have seen some of this information communicated to the government, and looking back across these different experiences, if you have recommendations about how researchers or organizations like EngenderHealth or universities should best present like evidence or share information and work in partnership with like government of India.
Certainly, because whatever policies are made, so those policies are made based on the available evidence. So we really continue to invest in creating evidence. But sometimes what happens, the evidence, the policy maker, asks for local evidence. Sometimes, we refer to evidence outside India, and then people question the evidence. And sometimes the evidence is created at a very kind of small scale evidence in a particular state, So I think whenever as a researcher, we are proposing to collect an evidence for a particular problem, it has to be locally generated evidence. And it is best to, engage the local universities or local institutions. Because sometimes, nowadays it has been noticed that even the government of India, keeps questioning the evidence generated by, let's say, foreign agency. Now, EngenderHealth is a foreign agency. And if I develop an evidence, they may say you might have a conflict of interest. So I think the best course of action is that's why I said, we work with the community, we work with the health system, and we try to build the capacity of the local people. And whatever evidence we generate or work we do, we always, partner with the local field implementing partner. If it is a project implementation, we identify a local partner. And if it is a research or evidence generation work, we identify a local part. And then, with my experience, it has been noticed that acceptability is better. But acceptability depends not only on the evidence also, because at the government level, the decisions happen, keeping, many things in mind. Sometimes, there are political priorities also there. And as you all may be aware, public health decisions are not always scientific. There is a politics behind it also, because particular government wants to give priority to some area. So then you start generating those evidence. So that means, as a researcher, message number one is that we engage with the local institution. So take their buying in, they become part and parcel, they start owning the data, so that nobody questions the evidence generated. So that's a one piece of advice. And the second is you have to understand what are the priorities of the government at that point of time, because priorities also keep changing over a period of time. Maybe now the priority is women's health, or maybe few years back it was a priority on newborn health. So I think we will have to continue to assess the priority, and our research, while conducting a research or planning to conduct a research, must understand the priorities of the government, both political as well as the ministerial priorities. So we should work within that range. But sometimes, we start, talking about creating evidence which doesn't come under their priority. So obviously, that will not be accepted, and it will be a waste of research. Because as you rightly said, 70-80% of the research which are happening, they are not getting converted into policy. So I think this is, one area where one can always invest and think, strategically while doing it. Thank you.
Maybe time for one more question. Yeah.
Thank you again for that really comprehensive set of insights. I think it was a nice snapshot. You mentioned about the reproductive health service utilization between the public and the private sector, and how reproductive health is predominantly in the public sector, and how it's important to increase the private sector involvement. Sometimes that can be a bit tricky. One of the strengths is the engagement of the public sector for reproductive health, isn't it? Because we see that where there's more private sector involvement, the costs are really things like cesarean